It's kind of you to invite me here, John, and I hope you don't hold it against me that I steal a lot of ideas from people here at Hoover. It's true, I steal monetary policy ideas from John Taylor. I steal rule of law stuff from Richard Epstein, and I even tried to steal some wit and humor from Peter Robinson this morning. So if this speech falls flat, blame Robinson, all right? But today I'm here to talk about health care. This is a subject that I find it hard to be funny about, especially since the Democrats stole all the health care jokes and enacted them into law. Had to pause for that one for a second there. Unfortunately, the consequences of this law are no joke. And the first step toward true patient-centered health care reform must be the full repeal of the president's disastrous new law. If we engage the nation in a serious debate and put forward a principled reform agenda, then I think that the odds are really pretty good that the Republican Party will soon find itself with the opportunity to do just that. But we cannot simply stop at repeal. We also have a responsibility to fix the broken network of government policies that have made such a mess of health care in America. If that process and if that notion excites you, it should. We have the right ideas on health care, and a change of power in Washington would bring with it an opportunity to turn these ideas into good public policy. But if that prospect worries you, well, I can understand why. The political hurdles that stand in the way of real, structural health care reform are daunting. And while Republicans have advanced many good ideas in health care, it is my candid opinion that the party as a whole has yet to coalesce around a complete reform agenda aimed at dealing with the underlying problem, which is runaway inflation in the cost of health care. Today, I want to attempt to make a case for optimism. Specifically, I come bearing three pieces of good news. First piece of good news is this. The urgent need to repeal and replace the president's health care law, coupled with the urgent need to deal with the drivers of our debt, will present us with an unavoidable time for choosing, allowing us to confront health care inflation head-on. The second piece of good news is this. Thanks to the tireless work of health policy scholars here at Hoover and elsewhere, we know what works and what doesn't work. Simply put, badly designed government policies are to blame for much of what is wrong with health care today, and the solution is clear. We need to transition from an open-ended, defined benefit approach of the past to market-oriented, defined contribution reforms that promote choice and competition. And the third piece of good news is this. Though the political hurdles are high, we know that we can win these fights within the conservative movement, across party lines, and across the nation. The challenge will be to summon the courage and the ability to offer Americans a true choice of two futures on health care, which is a choice that they quite frankly deserve. So the times require action, we have the right ideas, and the politics are clearly possible. Let's take each of these three reasons for optimism in order. First, we know we have the opportunity to enact reforms. Even before the president's law made matters worse, Americans faced serious problems in health care, and we simply cannot revert to the status quo. In the wake of repeal, we must be ready to advance solutions. To get the prescription right, we need to properly diagnose the problem, starting with the reasons why the president's law is such a failure. At its core, the healthcare problems is one of inflation, driven by the overutilization of services, dramatic underpayments, and massive inefficiency. If you look closely, the reason is easy to see. The healthcare sector lacks the most of basic building blocks of the functioning marketplace. For one thing, markets require transparent prices so that consumers can discover value. But in healthcare, the consumer is usually either a big insurance company or the government. Healthcare providers have no incentive to provide transparent prices to their patients because their patients don't pay directly. It's the government bureaucrat or the insurance company bureaucrat who pays the bills. Second, markets do not function well when the consumers are insulated from the marginal costs. We're all paying more for healthcare through much higher premiums and taxes, but the share we pay at the doctor's office has plunged. The system that shields us from the cost of services has actually left us paying much, much more. Rather than tackle these root drivers of the problem, the president's law goes in the other direction. It expands broken government programs, it enhances bureaucratic control, and it imposes flawed mandates that will continue to drive up the cost of care. Where there were cost-containing tools that help patients reduce their exposure to exploding costs, such as health savings accounts, the president's law essentially dismantled them. But the law's new open-ended entitlement programs are its biggest failure. One of them has been described as a classic insurance death spiral, and the other requires an additional $1 trillion in new federal health spending. Both are fiscally unsustainable, and estimates suggest that the costs would be much higher than initially projected. And that is ultimately where the president's healthcare law falls short. If you look at our debt and deficits problem, it's really a healthcare spending problem. Today, excluding interest, approximately 1/4 of government spending goes toward government healthcare programs like Medicare and Medicaid. By the time my 3 kids are my age, according to the nonpartisan Congressional Budget Office, the share of federal spending going to just pay for healthcare programs will reach 45%. And the new healthcare law does nothing to address the pressures that escalating healthcare costs are putting on the federal budget. In fact, our CBO director, Doug Elmendorf, said, in reference to the new law, it does not substantially diminish that pressure. Instead, it doubles down on the flawed design of open-ended, subsidized government health care. The result? Well, no secret. It's a healthcare system characterized by overutilization and inefficiency in which costs are rising at 2 to 3 times the rate of growth of GDP. As any family on a budget can tell you, when 1/4 of your budget is growing 3 times faster than your income, you are in deep trouble. All other priorities get squeezed as you fall deeper into debt. Well, that is exactly the situation our government finds itself in today. There is no serious dispute on either side of the aisle that healthcare inflation is the primary driver of our unsustainable deficits. As President Obama put it, quote, "If you look at the numbers, Medicare in particular will run out of money, and we will not be able to sustain that program no matter how much taxes go up," close quote. And Democratic officials will even admit that the primary driver of healthcare inflation is the current structure of government programs. As HHS Secretary Kathleen Sebelius recently testified regarding Medicare's flawed fee-for-service structure, quote, "I would say that the current fee-for-service system, yes, is unsustainable." So the disagreement isn't really about the problem. It's about how best to control costs in government healthcare programs. And if I could sum up that disagreement in a couple of sentences, I would say this. Our plan is to empower patients. Their plan is to empower bureaucrats. Just last week, the president rolled out a deficit reduction plan that doubled down on his bureaucratic approach to controlling Medicare costs, first advanced in his healthcare law last year. The law empowers a board of 15 unelected officials, the Independent Payment Advisory Board, otherwise known as IPAB, not iPad, IPAB. This board is to hold down the cost and growth of Medicare to GDP plus 1%, reducing reimbursements to healthcare providers. Unless overturned by a supermajority in Congress, the recommended cuts dictated by this unelected board become law. Well, the president's latest proposal simply called for having IPAB to cut deeper. This board of bureaucrats will now be tasked with holding Medicare's cost growth to GDP plus 0.5%. To put that in context, Medicare is currently growing at 6.3% per year. Medicare's nonpartisan chief actuary, Rick Foster, has been clear on this point. Going from 6% growth down to the president's targets, using only the blunt tools that this law gives to the IPAB, would simply drive Medicare providers out of business, resulting in harsh disruptions and denied care for seniors. In fact, the deterioration of seniors' care that is projected to occur under IPAB would be so untenable, the board is unlikely to yield any savings at all. Future Congresses would be under tremendous pressure to undo the cuts, just as past Congresses have time and again reversed the scheduled cuts to physicians' pay. Pain cannot be sustained. You cannot control costs by using price controls. These impose painful cuts within a fundamentally broken framework. Instead, you have to revisit the structure of federal health policy and change the incentives, something that many leading Democrats, with their unwavering commitment to early 20th century social insurance models, seem to remain totally unwilling to do. This leads me to my second piece of good news. We know that there is a better way forward, a way that accounts for both the benefits and the failures of those 20th century models and builds upon the good while reforming the bad. The House-passed budget offers a better way to strengthen Medicare and save it from insolvency. Instead of using cram downs that simply pay providers less while jeopardizing seniors' care, our budget proposes real reforms designed to slow the growth of healthcare costs economy-wide by promoting true choice and competition. Empowering seniors, not bureaucrats, is the best way to save and strengthen Medicare. At a House budget hearing just last July, Chief Actuary Rick Foster gave evidence in support of this approach, and I want to quote, "We've estimated for many years that competition among plans in a premium support setting like this could have advantages and lead to somewhat lower costs for Medicare. It can get you to the lowest cost consistent with good quality care," close quote. And not just in Medicare. Choice and competition are critical to controlling costs and throughout the entire healthcare system while improving quality for patients. And yet across the federal landscape, choice and competition are undermined by poorly designed programs and tax policies. In Medicare, the government reimburses all providers of care according to one-size-fits-all formulas, even if the quality of the care they provide is poor and the cost is high. This top-down delivery system exacerbates waste because none of the primary stakeholders has a strong incentive to deliver the best quality care for the lowest possible price. In Medicaid, a flawed federal-state matching formula is blowing out state budgets. There is no limit on the federal government's matching contributions to state spending. So, state governments spend most of their time devising ways to maximize how much they can get from the federal government, rather than focusing on delivering high-quality, cost-effective coverage for most of their vulnerable citizens. Beyond these two programs, our current tax code provides additional fuel for runaway healthcare inflation. Under the current law, employer-sponsored healthcare plans are entirely exempt from taxation, regardless of how much an individual contributes to their policy. This tilts the compensation scale toward benefits which are tax-free and away from higher wages which are taxable. It also provides ways for high-income earners to artificially reduce their taxable income by purchasing high-cost health coverage, which in turn can fuel the overuse of health services. The new law's attempts to deal with this problem will not work. They merely add a layer of taxation to a flawed tax structure when what we need is to change the structure from the bottom up. All of these structural flaws push affordable coverage out of reach for millions of Americans. Programs designed to shelter individuals from prices of healthcare programs, they have backfired. Instead, these programs have the unintended consequence of increasing healthcare costs for all Americans, causing rising premiums to road workers' paychecks and leaving many Americans with no coverage at all. The solution in each of these areas is to move away from defined benefit models and toward defined contribution systems. Under a reformed approach, the government would make a defined contribution to the health security of every American, rather than continue to offer open-ended, well-intentioned, but ultimately empty promises. The growth of these contributions should be capped to ensure the inefficiencies that have led to healthcare costs to spiral out of control are reduced. But they also should be adjustable so that more help goes to the poor and the sick, while the less financial support goes to those who are fortunate enough to need it the least. In other words, defined contributions should underpin a system driven by patient choice and centered on patient needs, the one that offers real security instead of offering empty promises. In Medicare, a patient-centered reform means premium support. This is the approach advanced in the House-passed budget and also on a bipartisan basis with Alice Rivlin and other Democrats who understand the need to move toward increased choice and competition in health care. In Medicaid, patient-centered reforms mean block grants to state governments so that they are freed from the onerous federal mandates and empowered to design Medicaid programs to meet the unique needs of their citizens, such as providing vouchers to low-income families so they have the dignity of having private insurance just like everyone else in society has. Many governors wrote to us after we included this reform in the House-passed budget to simply thank us for advancing an idea whose time has come. And with regard to health insurance for working Americans, patient-centered reform means replacing the inefficient tax treatment of employer-provided health care with a portable, refundable tax credit that you can take with you from job to job, allowing you to hang on to your insurance even during those tough times when finding a job is a hard thing to do. We should empower patients, not only with the resources and choices, but also with information. Patient-centered reform must promote transparency on price and quality, and give patients the incentive to act on this information. By putting the power into the hands of individuals, we can let competition work in healthcare just like it does everywhere else. Instead of top-down price controls imposed by 15 bureaucrats at IPAB, let's try bottom-up competition driven by 300 million consumers. We know that the first step toward real bipartisan advances in health policy must start with full repeal of the president's partisan law. But the case for repeal must be matched with even greater intensity by a case for replace. Replacing the law with structural reforms and real solutions to the problems Americans are facing in health care. The three reforms I've just outlined, premium support for Medicare, block grant for Medicaid, and tax reform to correct the inefficient tax treatment of health insurance, must be present in our replace agenda. If we end up with a replace agenda that fails to fix the problem, then we will simply lose the hard-won credibility on the healthcare issue as a result. Look, I understand how daunting the politics of these issues are. I've lived them, so I know that the political hurdles to real reform are great. But we can clear these hurdles if we combine political courage and clarity of purpose with faith in the American people. I'll be honest with you. When I first put out my roadmap for America's future a number of years ago, if you had asked me whether I would take the bet on whether we would have premium support in our budget this year, well, I would have needed pretty good odds to take that bet. One of my own staffers who helped me write this thing recently reminded me, I would have laughed out loud if you told me that. Well, here we are today. All but 4 Republican members of the House of Representatives and all but 5 Republican members of the United States Senate Republican caucus voted for our Path to Prosperity budget, Medicare reforms and all. And though we took a few dings at first, we survived. The Democrats tried the same old scare tactics for a few months. And in the first special election that took place after our budget passed, we learned a costly lesson. We learned that unless we back up our ideas with courage and defend them in the face of attacks, we will lose. But once we learned that lesson and started to get our message out, well, a funny thing happened. People listened. They learned that our plan did not affect those in or near retirement, that it guaranteed coverage options like the ones members of Congress enjoy, and that choice and competition would drive costs down and quality up. They also learned more about the Democrats' plan for Medicare, and they didn't like what they heard. And the scare tactics stopped working. Just look at what happened earlier this month in the recent special elections next door in Nevada and out in New York. The Democrats threw every scare tactic they could think of at the Republican candidates running in these 2 special elections for vacant House seats. But the attacks failed to connect with voters hungry for solutions, and the Republican candidates prevailed. Now, certainly, there are some mitigating factors in these races. The economy is unquestionably at the forefront of the nation's concerns, and the president's unpopularity definitely played a role. And in Brooklyn, the race to replace former Congressman Anthony Weiner, well, I don't want to get into all the factors that influenced that race. As Peter Robinson reminded me this morning before we taped this program, if you want to talk about the New York race, remember this is a family show. Um, here's the point. The point is that we should not fear false attacks again in 2012. Fear and demagoguery are the last refuges of an internally bankrupt party. And the moment calls for leaders who are not afraid to be honest with people about how they would solve the problems that we face. In healthcare, we owe the American people a defining choice. And the choice is this: who do you want to be in charge, the government or the patient? What we need in healthcare is more efficiency and productivity so that the pace of rising healthcare costs slows in the coming years. How is that going to come about? Certainly not with more bureaucrats running things from Washington, D.C. They've been trying that for decades, and they have only made matters worse. What will work is empowered consumers looking for value. Give patients and consumers control over healthcare resources. That would make all Americans less dependent on big business and big government for our health security. Give us more control over the care we get, and force healthcare providers to compete for our business. So those are my 3 pieces of good news. We have a great opportunity to enact real reform in healthcare. The wisdom of our leading thinkers has shown us how to do it, and our budget has demonstrated that we can survive the demagoguery and the attacks if we gather our courage, stay true to our guiding principles, and contrast our approach with the same old failed policies offered by the defenders of the bankrupt status quo. This is how we are able to defend our Path to Prosperity budget. It is how we are able to defuse the Medicare attacks in 2 special elections, and it is how we will unite the country to do what is right, both for this generation and for the next. Thank you very, very much. Appreciate it. I'd be happy to answer any of your questions. You may. Sure.
Let me ask about your personal health care. If I recall, your father, grandfather, and great-grandfather died of heart attacks young in their lives. What are you doing to try to make sure that doesn't happen?
Are you a cardiologist? My uncle is. Ryan hasn't lived in my direct family to the age of 60 in 3 generations. So my dad died at 55 at a heart attack, grandfather 57. Work out every single day, stretch on the 7th day, so work out 6 days a week, watch my diet, and just kind of pay attention to it. I'm 41. My uncle, who's a cardiologist, says I need to start taking statins as sort of a preventative. I'll get around to that, I suppose, but I don't want to get too deep into my own personal healthcare issues here. But to me, it's about exercise and diet, and get those things right, and you're going to be okay. Yeah.
Congressman, I'd like to hear your plan.
Oh, wait, you got to wait for the mic. She seems to be.
Oh, sorry.
Yeah, sorry.
Thank you. I'd like to hear what your plan says about the health insurance industry. I think it's great to foster competition among the insurance companies, but it seems to me the trend has been for consolidation of the health insurance industry. And I think, you know, the increased mandates of the Obama plan about pre-existing conditions, you know, those are legitimate issues, but obviously they're going to run up the cost of health insurance. And many health insurance companies spend far more of their premium on administrative costs, executive pay, and so on. So isn't it important to include some reform measures of the health insurance industry as a part of this plan?
Yeah, look at the incentive structure for health insurers. It's get a pool of people that are relatively healthy, make your spread with your reserves, and then after the pool sort of ages out, start over again. So I would say the incentive structure is misaligned between the patient and the insurer. So you want to align those. Whatever you do, don't do what the current law does, because the current law is going to lead to a massive consolidation of health insurance companies. You know, a lot of smart economists and actuaries tell us there are going to be about 5 or 6 insurers left in America when it's all said and done, when the president's healthcare law comes into force. They'll basically be de facto public utilities. I met with one of the largest insurers and their actuaries not too long ago who told me, well, we currently manage Medicaid for several states. And now that we're preparing for this new healthcare exchange, the health insurance that we're going to be offering in the exchange, and all of our competitors will as well, is the same thing as Medicaid. So it's really kind of bring us to a Medicaid for all system. I really believe that the current system will collapse. Number one, the President's law is designed to encourage employers to dump their employees into the exchange, at which they'll have a few choices to choose from between insurers that are basically federally managed and regulated. So I'd go in a completely different direction. Number one, let's have more competition within insurance, not less. Interstate shopping is a big part of that, I think, which is allow people to buy insurance across state lines. Number two, let's look at what is driving up a lot of costs. I think transparency is a big, important part of it. So you have a shopping incentive, you have insurance products where you have more skin in the game as a consumer with higher deductible plans. You can design these in many different ways so that a lower income individual has the resources within their, say, health savings accounts to buy it. So you have that shopping incentive, that consumer approach put in there. But number three, the actuaries tell us that as much as 8% of the under 65 population in America are in the category we would call pre-existing conditions. So that's where a lot of the costs go to. And those are hard to predict, who's going to get that. And it makes the price of insurance much more volatile. So why not finance risk pools at the state level to cover that population, protect their premiums from sticker shock. So the woman who's 47 years old who gets breast cancer, doesn't have to sell her house and go bankrupt just to pay for her Avastin injections. Have that paid for, protect her premiums, but you do a couple of things. Not only do you prevent that woman from going bankrupt, you get her into a system that has preventative medicine and disease management, you dramatically stabilize the pricing of risk for the other 92% of the population that is not in that category, and you dramatically improve the competition and pricing of insurance for everybody else. So to me, put the money where it ought to go. We spend 2.5 times per person on healthcare in this country more than any other industrialized world. We spend about 17% of our economy on this area. So instead of running the money through third parties, run it through the individual. The money ought to go to the people who need it the most, the poor and the sick, and away from those who need it the least, the wealthy and the healthy. And do it in such a way that encourages competition so that insurers and doctors and hospitals and other providers are competing against each other for our business in a patient-centered system where they are the nucleus of the healthcare economy, not the result. I can go on and on, but I would simply say more insurance competition, more transparency, find a way to deal with the pre-existing. I think risk pools are probably the smartest way of doing that, so that the insurer has more competition for your business, not less. And I think that's a fundamentally different approach. You have to deal with the lawsuit issue and a lot of other things. And I think if you do those basic building blocks of a market economy, I think you'll have far, far better results. And this sector of our economy will be a source of innovation and growth and not a drag on our economy. Sorry for the long answer, but it's an important question. Yeah. How about that? Oh, okay.
You mentioned sort of earlier about sort of the lawsuit issue. I was sort of curious as to what your thoughts were on tort reform in the healthcare industry, because one thing that's really distorting the economics of our healthcare system all up and down the line is this issue. So I was sort of wondering what your thoughts are.
Absolutely. It's a no-brainer. I mean, it's just sort of the list of things you need to do, it's just way on top of the no-brainer list. And so and we can pass these bills. We have through the House. We have many times. Our problem is getting through the trial lawyer gauntlet in the Senate, where you had to face a filibuster. That is a reform that can be filibustered, and we've never been able to get over that. And it's not just the premiums doctors pay, which are high, especially for OBGYNs and others. It is the defensive medicine that is practiced as a result of it that pumps so much overutilization of healthcare into the system that is a huge cost driver. And so to me, that's just part and parcel of any legitimate reform to get at the root cause of health inflation. Yeah.
Congressman, can you be a little more specific about your ideas on specific tax reform that would affect the deductibility of health insurance? I mean, I think this is a huge issue and could have a profound effect in a positive way of reducing costs.
Sure, I'll give you the specifics on a bill that I authored in the last session of Congress with Senator Tom Coburn, Richard Burr, and Congressman Devin Nunes from, he's just down south of here. I would argue that the tax treatment of health care is one of the key drivers of health inflation. And the way it works today, it's about, off the top of my head, about $3.5 trillion is dedicated toward this tax benefit, which arose out of World War II wage and price controls. And it gave rise to the third-party system we have today, which shields people from price sensitivity, cost sensitivity, and has been, I think, a source of inflation. So what we're saying is, rather than tie your tax benefit to your job, which, by the way, we're subsidizing people in the highest tax bracket the most and people in the lowest tax bracket the least. That's upside down. That makes no sense. So instead of having your tax benefit tied to your job, which gives rise to this third-party payment system, delink that tax benefit to the person, to the individual. In across the board way, specifically what our bill did was it was $5,700 for a family for a refundable tax credit. If you're on Medicaid, you get even much more than that, about $12,000, to go toward your out-of-pocket costs for health insurance. Now, here's the key thing. A lot of people get this confused with employer deduction versus employee deduction. The employer, under what we've proposed, still has the ability and the right to write off the provision of health insurance for their employees. So we're not trying to dismantle the employer-sponsored system, which I would argue the president's health care law does. We simply want to equalize the tax treatment. So employers still have the same incentive to offer their employees health insurance, but their employees, instead of having to get this benefit from the job, is given to them. So what happens if they change jobs or lose their job? They still get this tax benefit then to help them with the purchase of health insurance versus the status quo, which is if you lose your job, you lose your tax benefit. This is not the 20th century. You don't have the same job for the rest of your life anymore. It's not how the economy works. You move around and change jobs, so we should make this benefit more portable. And I would argue that gets more skin in the game, that gets more consumerism into the system, and that helps get at the root cause of health inflation. So that's the way the numbers work in the last bill that we wrote. That's right. This is on top of the deductibility at the corporate level. That's how we've always proposed it. Oh, the guy in the back.
You've talked about moving from a paradigm of defined benefit to defined contribution. Can you help me visualize how this would work with a couple examples? Maybe if my son breaks my leg or my mother gets cancer.
Your son breaks your leg or his leg?
Sorry.
Yeah.
My son breaks
Boy,
either.
I don't want to get into the relationship between you and your son, you know.
Let's say he breaks his leg or my
Okay.
mother gets cancer. How would this work in terms of how it works now with defined contribution versus, or defined benefit versus a defined contribution?
Not a big difference from the way you see it as it is now. So let's take your son who breaks his leg. You already have health insurance. You have a tax benefit for health insurance right now if you get it from your job. You don't if you don't. So this makes sure that you have that tax benefit. You will have gone out and purchased health insurance, and that will cover your son's leg break over your deductible. You decide what deductible you want. If you want a high deductible where you have an HSA, so you're a little more sensitive, and you check out, where the best place to go to get his leg fixed. More to the point, people, here's the knock on this idea. They say, well, what if I'm in the ambulance rushing to a hospital? How am I going to do cost comparisons and shopping around? You're not, is the answer. But more importantly, you're going to be in an ambulance, your son's going to be in an ambulance with a broken leg going to a hospital that has been subjected to all this consumer pressure already, where the hospital has been saying, if we want to win business coming through the door, we have to be better than the other hospital. We have to show that our value, our price, and our quality is top-notch so that we can bring in customers. And that's who we're focusing on, customers. So your son, in an emergency situation, will have benefited from a system that has had that kind of market scrutiny placed upon it. For your mom, when she gets cancer, either whether she's under 65 or over 65, she would have the kind of catastrophic coverage that would take care of that, whether it's in a risk pool for an under 65 person or in a Medicare system, which a premium-supported Medicare has catastrophic coverage. It gets you, the way it works for me as a member of Congress and a federal employee, is I get a book or I go online that the HR department of the federal government, the Office of Personnel Management, gives me a range of plans to choose from. These plans compete against each other for my benefit, and I decide, do I want the basic plan? Do I want an HSA? Do I want something, with lower deductibles, therefore higher premiums? I choose. They compete. I win from that. And under this kind of a system that we propose in premium support, as people get sicker, so like if your mom who's on Medicare gets cancer, her payments go dramatically up to reflect that higher cost to prevent her from having huge sticker shock when she gets ill. So what we propose is adjusting those premium support payments. Alice Rivlin and I worked on this idea in the Bull-Simpson Commission. This is an idea that was first proposed by Bill Clinton's bipartisan commission to save Medicare. It's an idea that has traditionally had a lot of bipartisan support in the past, but I would argue partly because of ideology and because of politics is being attacked now for political reasons. But this is the best way to save Medicare so that we can keep control of our own healthcare destiny. If we go down the current path we are on, IPAB and price controls, all that will simply result is current seniors will see their care denied and rationed through price controlling. What we're saying is get rid of IPAB, don't change the benefits for people above the age of 55. Meaning, my mom who's 70, I shouldn't say how old she's in her mid-70s, you know, so she didn't like it when I say how old she is. So my mom who's in her mid-70s, you know, it's too late to change it for her. And the great part of it is if we go soon, we don't have to. So she keeps the Medicare, she organized her life around the system she paid into all those years. And if we can change this for your generation, my generation, 54 and below, when we retire, we will actually have a system we can count on. And that is a system where reform is working in the right direction to bring consumer pressure and price competition where we need it. So for the lady who has cancer, for the kid who breaks his leg, you want them going into a healthcare system where society finances the people who need the help the most and not the people who need it the least, and has a patient-centered system that is derived on competition and choice based on transparency so that he benefits from the best possible care he can get. That's the kind of system we're talking about. How about up here?
If there's any validation about the flawed nature of the Obamacare, it would be all the waivers that have been granted.
1,400 waivers.
So of the 1,400 waivers, approximately.
You got a bunch here in San Francisco, I noticed. In a particular congressional district.
That's correct. Are they, well, first of all, who grants them? Are they permanent or temporary?
No, they're 1-year waivers granted by HHS.
And does that exempt you from all the mandates and rules and taxes and the $2,000 fine per head if...
Oh, you mean the waiver itself?
Yeah.
Oh,
so how do those waivers work?
Sole discretion of the Secretary of HHS designs what kind and how large the waivers are. So not every waiver is exactly the same. So the Secretary of HHS, this is sort of how progressivism sort of works in practice, which is given an unelected bureaucrat the authority to decide. And she, in this case, decides who gets the waiver. They last for 1 year. I call them stays of execution. So, you know, there are 1,400. If there's any great metric as to the controversy or the ineffectiveness of this law, the authors of the law or the promoters of the law have given out these 1,400 waivers just this past year, and those things expire at the end of the year. So it's up to the discretion of HHS as to what shape, form, or if you get this waiver. That, to me, is just a perfect recent example of a bureaucrat picking winners and losers. That is not equality under the law. That really upends the rule of law and replaces it with the rule of bureaucrats, which is sort of undermining one of the cornerstone principles of our system. And when you upend the rule of law, such as what this does, it really turns our system upside down. And it's damaging, not only to democracy, but it's damaging to policy in our system. Yeah.
Congressman, could you comment on the effect of Obamacare and then how you would think differently about how do we attract the best and brightest to be doctors, and how do we get the kind of innovation to get the kinds of devices and drugs that can make so much difference?
Boy, you don't do it the way we're doing it now. I mean, think about it. I got a lot of friends who are my age, who are doctors, who are seriously contemplating switching careers, going somewhere else. You know, if you're in your 50s or 60s, you're going to see it through. If you're in your 30s or 40s, you're thinking twice. And if you're a smart kid in undergrad who's going to decide to rack up about $250,000 in student loans to go into this kind of a system, you're going to think twice. Here's our problem. The baby boomers are here, and we're not ready for them. 10,000 people are retiring every day today. We're going from about 40 million retirees to 77 million. And we don't have enough people going into this important field to take care of them. And so that's the other thing. Our serious work shortage, labor supply shortage is occurring, I think, because of this law. Because of this law stunts and denies innovation. It puts a chilling effect on research, on development, and innovation because it's a one-size-fits-all federally run system, a price-controlled system. And so that's what I say. The healthcare sector ought to be an asset to our economy, not a liability. And this moves this sector of our economy closer to the liability stage where people feel like if they go into healthcare, they're not going to be able to apply their talents in innovation. You know, Alan Enovan, isn't he affiliated? I mean, he's written so much about this. You have so many good scholars around here who've written about this stuff. That's what I worry about the most, is this is going to put a huge chilling effect on the talent we need to go into this sector to get the new cures, the new developments, and just the smart, hardworking, intelligent people to deliver these services. And I really worry that this is going to put a huge chilling effect on that sector of our economy where we need it the most. Yeah, how about the lady?
Could you say a little bit about the broader debt picture and in particular handicap the likelihood that the Special Congressional Commission will reach a deal that'll prevent sequestration?
The broader debt picture isn't very good, I would say. This is our fourth year of trillion-dollar-plus deficits. If you ask GAO what the promises government is making to people today that it's short of paying for, that number is $99.4 trillion. Last year was $76.4 trillion. The year before was $62.9 trillion. So our unfunded liability, meaning the promises our government is making to today's Americans, my mom, me, and my kids' generation, that's about $100 trillion shy. We go over $10 trillion deeper in the hole. So we're getting closer to that tipping point where the debt gets away from us, meaning we lose control of it. What I mean when I say that is just the interest on the debt can start compounding away from us. By the end of the decade, under the current estimate, which is low in my opinion, we're dedicating $1 trillion just to interest payments. By 2025, Medicare, Medicaid, and Social Security plus interest consume 100% of all federal revenues by 2025. So this thing's starting to get away from us. And this is why we've put out these plans to say, let's do this now while it's on our terms, before it's too late, before we have a European austerity situation on our hands. What all the smart economists like John Taylor and Michael Boskin and the fixed income people tell us is we have about 2 to 5 years, probably closer to 2 now than 5, to fix this problem, get it right, and do it on our terms. So what we're trying to do is get the confidence and trajectory going the right way, get the debt going down, which is what our budget does. Our budget, using CBO numbers, pays off the debt. It goes beyond balancing. It actually pays off the debt and gets it under that danger zone, gets it below 60% of GDP, prevents it from ever getting to 90% of GDP, which is a tripwire for slow growth, and gets it under control by addressing the drivers of our debt, which are chiefly these healthcare programs. That's why we spend so much time talking about healthcare. The Select Committee, so meaning we don't have a lot longer before we cannot do this on our own terms, and we have a European austerity situation, cutting current seniors, cranking up taxes, slowing the economy, making it harder for young people to get ahead and have a better standard of living. The Select Committee, its job is to cut $1.2 trillion in spending, or savings. That's not that hard in my opinion. The budget we passed cut $6.2 trillion. So we can show you many different ways of arriving at a $1.2 trillion number. The challenge and the question, which I just don't know the answer to, is whether our partners on the other side of the aisle will agree to some combination of cuts to get us to that 1.2. Do I believe that a grand bargain will occur? No, I don't. And I would argue that you shouldn't have 12 politicians cutting some big grand deal, fixing all of our fiscal problems in our country. That's not how it should be fixed. It should be done by all of us in Congress. So I think they will get something at or below 1.2. And whatever they don't get going to 1.2 will be made up for by the sequester. And the concern, obviously, a lot of us have is this is a big hit to defense. 50% of the sequester hits defense. And so that's quite unnerving given our challenges. So we want to get to 1.2. I'd love to go beyond that. You know, I went to 6.2. But we'll see. They have to have this done by Thanksgiving. It's not that difficult in my mind to do it, but the question is, will there be a political consensus there? I think there will be, but I don't know if it's going to be as much as 1.2, and whatever it isn't, the sequester will make up for the rest of it. What that basically means is the 2012 election decides the rest of this. The 2012 election decides on who the country sends to our government, the House, the Senate, the White House, to fix this problem, and that will determine the outcome of these issues. That will determine whether the sequester goes and takes all this out of defense, whether we fix these entitlement programs or not. So the super committee ought to get a good agreement. It'd be a confidence boost for the economy. It shows divided government works, but it is not going to fundamentally fix our problems. And where it falls short, the rest will be made up by the sequester, and the people who are leading the country in 2013 will figure out the rest, because they'll have to. Yeah.
How would you counsel Mitt Romney in his defense of Romney Care, and is he open to some of these ideas that you're talking about today?
You know, I haven't talked to him in a long time. I know I've talked to him a little bit about Medicare reform in the past. I think he's fairly familiar with these ideas. I think he did sort of discuss in his, I forgot what he calls his plan. He discusses the general principles of defined contribution healthcare reform. So I think he's, in theory, open to these ideas. I'm not a fan of individual mandates. I don't think they work. I'm not sure how I would counsel him to defend Romney Care, only that I think he's doing the best he can, which is, this is something we did in Massachusetts, which was what we decided to do in Massachusetts. It's not what I would prescribe for the rest of the country. And he's been pretty clear about how he doesn't think the president's health care law works. So I think he's probably done as best a job as he can, given the circumstances and the policy ideas behind the health care mandate in his state. And the way I look at this campaign is it's still in the early stages. It hasn't advanced in the mature policy stage. And these candidates are going to, I assume, get into Medicare, healthcare, not just Social Security, taxes, and get into more specificity. Because I, for one, believe it's our obligation. We owe the country a choice. I mean, we have to give the country the choice of, do you want this path or that path? We know where the president's going. I mean, he's made it pretty clear, and he's doubling down in that direction. So what we owe the country are specific solutions using our founding principles applied to the problems of the day to reclaim the American idea. What I would refer to as that opportunity society with a safety net. A system designed for and described by prosperity, upward mobility, where we see the role of government as to protect our natural rights and to promote equality of opportunity, not equality of outcome. Not a system which would be more described as a cradle-to-grave welfare state, where we turn the safety net into a hammock for able-bodied people. That's where I think the president's policies are taking us. And that's not who we are ever meant to be. It will stagnate our society. We will not have an elegant decline. And that's the choice we have to make in 2012. And these candidates, I think by virtue of just necessity out of the times, and what we think we've done in the House is raised the level of debate and discourse and policy discussion to require that we offer the country the choice that they deserve. And I, for one, think in this center-right country, if we give the country the choice, they'll make the right one, and then we'll have the moral obligation and authority to fix these things before they get out of our control. Yeah.
Last time that you were speaking to this group, you talked about what was going on in Wisconsin. Can you maybe update us now that the recall elections are past us and tell us what that means for the United States?
Well, that's Wisconsin obviously is a harbinger of things to come. So in Wisconsin, I won't go through all the collective bargaining issues. I assume most people know what happened in Wisconsin with the budget repair bill that the Governor Walker passed. What happened was the left dumped somewhere between $25 and $30 million into Wisconsin in the summer to try and retake the state Senate. They failed to do that. I mean, it was oversaturation of political organizing and ads and all of those things. They didn't take back the state Senate. There's talk of another round of recall starting back up in January because a year will have elapsed, and then new legislators you can recall them. They may try and recall our governor. I don't think these will be successful. People are getting tired of this stuff. But more to the point, the world didn't come to an end. Now that these reforms have been put into place, what we are learning in Wisconsin, school district by school district, city and municipality by city and municipality, is that these tools brought to the local government level made it easier for teachers to stay on payroll, meaning they didn't have to fire as many teachers. They could outsource their health insurance bidding. They could do things like merit pay and stop last in, first out, and promote better educational reforms, meaning they could keep government services without having to raise taxes, or they could keep government functioning without deeply cutting services. 50% of Wisconsin's state budget goes into labor costs. 65 to 80% of local government are labor costs. You cannot address the structural fiscal problems in our state and local governments without addressing labor costs. And so that's been done. The left had a huge attempt to try and reverse it. It didn't work. It didn't work in the Supreme Court race. It didn't work in the state recall races. But we're at halftime in this thing. And Ohio's got their referendum they're dealing with. But the reason you see so much of Ohio and Wisconsin on your TV is because our electoral votes are up for grabs. And Wisconsin is the most closely divided state in the country. 2000 and 2004, President Bush lost Wisconsin by less than 0.5% each time. So a Democrat has not won the presidency in the United States of America without winning Wisconsin since 1960. So this is more, I think, about the presidential election and the 10 electoral votes in these sort of bellwether swing states like Ohio and Wisconsin than anything else. And so far so good, but it's I just keep telling my friends and supporters and families and others in Wisconsin, this is the new normal. We're going to have this stuff for the next 14 months, and we're just getting ready and adjusted and prepared for it.
Other questions?
All right. Thank you very much, everybody. It was a pleasure. Thanks for having me. Appreciate it.